clinic for 21 years. So my patients I've treated for many years now, and they keep coming back and they ask me this question. Do I have to keep coming back? I like seeing you, but do I really have to come back? And I say, yes, you have to come back. Like, why? I have to justify my living, right? It's a fact. It's a fact. You can look at it any different ways, and I'm happy to talk about anything and everything. So the question comes up, and I think it's a fundamental one. Am I cured yet? And I can tell you in uveal melanoma, this has not been addressed. And I've always tried to find the topic for research based on what patients ask me. So when Yanni said, like, how do you know what to ask? What to study? I said, well, to listen to the patient. They're telling you what to study. They ask me, am I cured yet? So a little bit more, you say, do I have to keep coming back? So you take that and kind of refine it. It becomes this kind of question, right? Anyway, so we talk about tumor control in general. We talk about globe preservation, talk about visual outcomes, treatment methods, prognostication. But what really is, in the end, most important is the survival in any cancer business. So let's forget the eye for a moment. So cancer, survival is the ultimate currency, right? That's what you're interested in. So I want to come back to the question. And the question actually has deep meaning. Am I cured yet? Am I means it's individual. I'm not looking at 10,000 patients from SEER database and what happened to these 10,000 patients. I want to know about myself. Am I cured? It's very personalized, individualized. So that's the question I'm trying to answer. And what is cure? What do you mean by cure? Well, in my mind, the cure what patient has is freedom from metastatic death. Well, I die from it. That's kind of what I'm looking at. So that's the cure. Freedom from metastatic death. Not necessarily freedom from metastasis, but freedom from metastatic death. Because maybe, even if you have met in the future, you can live with it for many, many years. Right? So it's just that. So that's the question. And yet means like 5 years, 10 years, 15 years. Like, what are we talking? Indefinite? Could be, right? So the title is quite intrusive. It's giving you all the prompts. I'm going to answer this question for you. I have an answer here, okay? But this is what is behind all this. It took me a lot deep thinking to come up with this topic to talk about. So to answer this is a mathematical problem, okay? So let's get into some math. And I can tell you, math is the language of science, and math is the language of smart people. Both my children are into math. My older one did biostatistics from Harvard, and the younger one did PhD in statistics and econ from MIT. So we talk statistics at home all the time. I'll actually tell them something, and they say, Dad, you're not articulating your problem correctly. Okay, well, sir, well, tell me, how do I articulate my problem? I'm just posing. So they kind of convert into mathematics. They say, go and work on this so I can find some people here to help me. Okay, so you have to understand a little bit about molecular pathogenesis. And we have to talk about the data sets I mentioned to you about the population data SEER database. We're going to talk about excess absolute risk. And this is an important one. It's very easy to understand. Forget the math behind it. You say, okay, we know how people die in the United States. We say 60-year-old male, white male, let's say, by age and by sex. What's the chance of them dying at age of 60, at age 80, age 90? We know that from census data and others data sets. We know that, right? We know life expectancies, right? We all know that. That's fine. Then you take the population and you say, you separate them and say, there's one population that has uveal melanoma and the others don't have uveal melanoma. So only difference between the two is presence of uveal melanoma or absence of uveal melanoma. And you look at the outcomes and you say, patient with uveal melanoma died earlier, and therefore all deaths in that is due to uveal melanoma, because that was the only difference between the two sets of populations. Am I clear? So the advantage here is that, and you're all my patients, so I'm being respectful, I'm being both scientific. When patients die, they die somewhere remotely from where they were treated here, for example. Some nursing home, some hospice care, wherever. And you will never really be able to know in all patients the exact cause of death. Somebody may die of heart attack, somebody may died of accident or stroke or something. So how do you know what the patient died of? So it's a huge burden to prove whether they have metastasis or not. If I look at 5,000 patients and see 10 years later what they died of uveal melanoma, it will be hard for me to prove in every case that they had meds or no meds, because they may have a heart disease or diabetes or something. So statistically, it gets very complicated. Then your data makes not very pure, especially long term. I know what happened 1 year, we know 5 years. So when you ask your doctor what happens after 5 years, they can't answer that because we don't have high quality data. All this noise comes in. But there's a way around it, which I just told you. You kind of look at statistically that way. And that's the concept of excess risk. And then you talk about conditional survival. Conditional survival being this: if somebody is already 85, they're more likely to become 95 because they already lived through many things. They're healthy enough to become 85, so they're more likely to live 95. Versus somebody who is 60, his odds of becoming 95 are low, but unless he becomes 80, then his odds gets better. So this actuarial methods of life expectancy, more you live, longer you're going to live. Something like that. Yeah. That's the conditional. So we're going to use this also in this calculation. So we're going to answer this question. So what is needed to answer this? We need survival data on large number of patients, long-term data, high quality data, where cause, if we can know, fine, but if you don't know the cause, we can work around it with some statistical methods. So we're looking for relative survivals. Survival, that's a relative. Melanoma, no melanoma. That's the relationship. And then you say we calculate this concept of excess risk. And we say, yes, there is a data set, see a data set. I talked about that. So I found two smart PhD statisticians at Cleveland Clinic, Thomas and Emily. And we sat down, we said, this is over COVID. I didn't have so many patients that time. We wrote 3 big papers, and this is one of those 3 papers. But there is 2 other papers that go behind this in this background, trying to answer this question. And we say, what happens to patients over long term? Not 5 years, 10 years. What happens 20 years later? What happens 25 years later? Some of you are young, and you say, oh, I'm 30 years old when I got melanoma. How will it be for me when I'm 85 years old? So if you follow patients, this is 10,000 patients with uveal melanoma. Imagine they all happen today, and you follow them over time. After about 10 years or so, they start to die of other things, not so much from melanoma. So the red line is melanoma line, and other causes, obviously, you get older, you're going to die of something. We all have to die of something. We get that. And everything is trying to kill you, right? Heart disease, lung disease, lung cancer, everything is trying to kill me. I mean, that's what's happening, basically, right? The 1,000 things trying to kill me. Just depends what's going to get to me first. So if you are, that's one way to think about it. Right? Okay, so everything is trying to kill you. The day you're born, something's trying to kill you. That's the way it is. Okay. And so when you cross 10 years, you're more likely to die of something else. So you say, okay, I've already passed 10 years. That means the burden of death from melanoma diminishes or plateaus off, and everything else starts to catch up as you get older. That's what it's telling you. So after 10 years or so, there's like a switch. So if you already crossed 10 years, you say, maybe something else is going to kill me, not melanoma anymore. So that's that. So this is based on 10,000 melanoma patients. There's a switch right there. And if we are looking at 30-year outcome, we're looking at 40-year outcomes. Very little data on it. And it depends upon which method you use. There are 5 different ways of measuring it, and each method will give you a different number. But we really don't care about that. We say, I'm going to look at only those where I do not need to know cause of death, because it's impossible to establish cause of death with reliability unless I do autopsy on every patient that dies. And autopsy rate in the United States is only 2% or so. So there is no autopsies done just for many reasons. So we don't have that information. So we say, I'm going to use those statistical methods where cause of death is not needed. So we bypass that barrier. So we have excess absolute risk is one of those methods, and we chose that method. And so if you look at the patients, again, 10,000 patients, say, happen today, and go forward, 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 and you say, what's happening to them? These are the deaths happening in the first 5 years, starts to come down by 10, and comes down to base at about 25 years. So it takes 25 years to level off to match the rest of the people. That's what the curve is telling. Up at about 5, goes down by 10, then 10 to 15, then 20, and then by 25, it's coming down. It's taking too long to come down. Okay. But if you take this curve, you can break this down into 3 curves mathematically. You say this curve is the sum total of 3 curves. 3 kind of things are happening here. And what are those? You say one is early death, that's in pink, late death, that's in green, and no deaths. That's kind of at the bottom. So this curve, are you still with me? I haven't lost you yet. Okay, don't worry. This is published, you can read more about it. But this is what's happening. So there's kind of 3 kind of people, 3 kind of population, 3 kind of events. We can say in this Uveal melanoma people population. And we say no deaths are the ones that are cured. They didn't die from melanoma. So they are the ones we can say they are cured. But are they really cured? It's 25 years after treatment. Which treatment works 25 years later? You think I need to take treatment now and it will show me the benefit 25 years later? No. It's not cured fraction. I would say it's just a survived fraction. They just survived through it. You didn't get cured from this. It's telling us maybe our treatments did nothing as far as the outcome goes. Maybe we just take care of your eye. We really didn't affect anything. So this is called palliative. Not palliative. You heard about palliative care like terminal patients. That's kind of not what I'm trying to say, but this is, that means it's limited only to the eye, because the benefit is showing up 25 years later, therefore it's not benefit, therefore treatment has no effect in terms of survival, and it's palliative. So this is not cured fraction, it's survived fraction. You somehow survived it because you had good luck, or you had good genes, or something. Something, I don't know what. So conceptually, it's taking me to the point that our eye treatments are very limited. Therefore, we talk about adjuvant therapy. I said was going to make a difference here. But let's for a moment say this survived fraction, and that's actually about 60%. Okay, so 60% of people will survive uveal melanoma, not 50, not 40, it's 60. Okay, that's now we understand that part. And then we went back and had 800 patients with genetics of the tumor. And we found that correlation, that early deaths were those patients that had BAF1 mutation in the tumor. Late deaths came from SF3B1 mutation. There was a question about it yesterday online, and these patients had none of these mutations. So that means that it's called wild type. So that means the mutations, the tumor are driving this, and there's a different profile of survival based on the tumor markers, not in the blood, but tumor markers. And so these curves are all explained by that. So this was 7,998 patients. So it's 60% at 25 years have survived. So they say, do I have to wait 25 years, Dr. Singh, to know I've survived this melanoma? Do I have to see you for 25 years? No, we'll come to that. So there it comes to this yet component of it. So we say conditional survival. Like I told you, if you live for certain years, you get better. So it's a dynamic estimate. So somebody comes at time 0, you say, oh, you have 70% chance of making out to 10 years. This is kind of what you hear, right? You say you have 70% chance, 80% chance. But the fact of the matter is, as you live through it, if you already lived 5 years, your chance gets better from 70 to 85. And if you live 9 years, you're 98%. So like from 70, your numbers get better and better. But we never talk about it, right? We always say, oh, at the time of diagnosis, you have 30% chance at 5 years. But the fact is, these estimates change. It's a dynamic thing, right? You're surviving through it, and so the numbers get better. So if you kind of continue this, And this 25 becomes actually 15. So we say that if you survive 15 years, statistically, you're cured from melanoma. Statistically. Okay, that's what it's telling me. So that's curious. So I moved from 25 to 15. I made only 10-year progress. Okay, we need to go further on that. This is just kind of where it's taking us. So we are nowadays, based on this, we can say, I can tell who will be cured. Now we don't know that. We go back and look at the patients who actually lived through it, mostly small tumors with good genetics. They are the ones who didn't die from it. So we know small tumors is better to treat. And all this is a descriptive. That means we know who will survive in general. We are looking backwards in many ways. And we are looking now more individual, personalized. We have to look forward, and that's called predictive analytics. And this will I be cured? Say, one is what happened to 10,000 patients? That's one thing. And more importantly, what about me out of those 10,000? So this is predictive analytics and requires a different level of rigorous statistics, and it's coming. It's coming. We're not there yet, but this is happening. So we talk about predictions, AI, all the stuff. This will come in that area. So we're not there yet. So we need prospective data so far, and some of it is coming. But we come back to this question, am I cured yet? So if you take home message, we say, yes, majority will be cured, 60%. So it's not 50-50, it's not 40, it's not that pessimistic, it's 60%. And you can also say, based on all these 3-4 papers together, you say it's a statistical cure at 15 years. So if your melanoma was diagnosed as 70, now you're 85, you say, I don't really care about many things. That's fine. You're pretty much cured from it. That's okay. And the chance of cure increases with time. So more you see me, better you get. Tumor size and molecular profile are the biggest things. We talked about the size yesterday, a little bit on it, and the molecular profile, and it's coming. So not just GEP, but actually the mutations. So GEP just say class 1, class 2. It doesn't tell you which mutations. And mutations are the ones I think that are going to be the more predictive. It's coming. The test is changing, and we are looking with Yanni. We're trying to do working with Castle. We just signed a contract with them to look at their data and our data together. So that's coming. This predictive analytics is coming. That's our next work. And then it's a work in progress and happens to be very slow. A little bit at a time. And that's all there is to it. Thank you.